Hi everyone. I know I said I didn't really have much time, but free time did become available, and I want to help as many seniors as I can. So I'm going to run through the outline provided for us for quiz number 5, and then you'll be able to see it uploaded very shortly, but by the time you start watching this, it's going to already be uploaded. So I first want to actually go all the way down before I start talking about like the questions themselves, a little bit about the anatomy of the heart so things make sense when we talk about heart failure, since that's chapter 25. So what I first want to talk about is how the blood flows through the heart, right? So blood or deoxygenated blood comes from the veins and it goes into this superior vena cava from the upper body or the inferior vena cava if the blood's coming from the lower body. Regardless of where it comes from, it enters into the right atrium, where it then goes to the right ventricle, then to the pulmonary artery, and into the lungs, right? So when right-sided heart failure patients have complications, they're not going to have complications in the lungs. It comes from wherever the blood came from. So in this case, the right side of the heart's job is to bring blood to the lungs, right? But in right-sided heart failure, they can't. Something goes wrong with the right ventricle. It cannot properly pump. And as a result, blood pools and it backs up. And where did it come from? We said the body. Now, going back into how the blood flows, right? So, if the right side is working perfectly, it goes into the lungs where undergoes like gas exchange, it becomes oxygenated, and then goes into the left atrium, which will then go to the left ventricle and then sent out through the aorta to get to the rest of the body. When the left side fails, right? Where did it come from? It came from the lungs. So when the left side can't pump properly, it backs up and pools into the lungs, and as a result, you'll get pulmonary complications, as well as potential systemic problems such as like oliguria or kidney problems because, right, if the left ventricles aren't able to pump the blood to the rest of the body, kidneys take up 25% of our blood flow. That's how much blood our kidneys need. So the kidneys become affected if the left side doesn't work properly as well. But most of the symptoms will be pulmonary related because that's where it backs up, right? Whereas for the right side, it backs up where? Back into the body. That's where it came from. That's why we'll see things like what we call systemic congestion, or we'll have fluid buildup in the body as a result of the right side not being able to pump properly. So it backs up into the body, and that's why we get the edema and all of those symptoms, right? Such as right jugular vein dissension, ascites, or fluid in the abdomen, right? Weight gain, splenomegaly, hepatomegaly, which is enlarged spleen, enlarged liver, fatigue, and even an increased central venous pressure. And if you think about it, right, if there's fluid building up in the body, right, that's going to increase pressure. So the central venous pressure is going to increase. So anyway, that's just the anatomy of the heart. So thinking of that, I want to go to the first question, which is to conduct a physical assessment of a client with left-sided heart failure, provide clinical manifestations, and anticipate findings when performing an assessment. Know the clinical manifestations of both right and left-sided heart failure. So I already talked about the anatomy. So right side pulls back into the body. So as a result, we're going to see body fluid buildup. So we're going to see edema. We're going to see distended or extended neck veins or JV distension, right? We're also going to have weight gain and fatigued. And we're also going to have an enlarged liver, so hepatomegaly, and those are our symptoms for the right side, for right-sided heart failure, right? So we're thinking about systemic problems, which we also call systemic congestion, right? Whereas left-sided heart failure, we said it backs up into the lungs, so we're going to have pulmonary complications such as dyspnea, rales and crackles, difficulty breathing, pulmonary edema, where we could see pink, frothy, or bloody sputum, and a nagging cough. Now, the other thing that I mentioned before is, as I said, the kidneys take about 25% of our blood flow. So when the left side of the heart fails, you could also have oliguria as a result of the body not getting perfused properly. And we could also have a decreased SpO2 as well as an S3 heart sound in left-sided heart failure. There could be an additional sound, right? And imagine if the left ventricle is responsible for sending blood all the way throughout the body and it can't, we might hear an extra sound because the body is keeping things, or the heart, I should not say the heart is keeping blood in that left ventricle when it shouldn't be. And another thing that she mentioned for this question is an echocardiogram, which basically measures the myocardial ejection fraction. And the ejection fraction is really important because that just means how well the ventricle is able to contract. So if that ejection fraction is low, that means the heart isn't able to pump blood wherever it's supposed to be, right? And that typically usually correlates to the left side of the ejection fraction. But think about it, right? If the ejection fraction is supposed to be above 40% and it's not above that, that means there's a problem with the heart. It can't contract properly. That's why we see patients start going on things like, as Dr. Remy said, pacemakers. If that doesn't help, they can have something called an LVAD, which is a permanent placement in the heart that helps the ventricle pump because the ejection fraction is so low that it can't do it themselves. And additionally, when the ejection fraction is low, the SA node won't really also be able to contract properly, which means there's a conduction problem. That's why patients who have heart failure also could have atrial fibrillation because of the problems with the conduction system. Okay. Other goals just include, right, like promoting activity tolerance. So making sure that they're on bed rest if they have like acute exacerbations, that they have regular exercise, right, for 30 minutes a day. If they feel like, pain or something going on, we have them stop, right? Making sure we perform activities to conserve energy and elevate the head of the bed to help with breathing, especially for those left-sided heart failure patients. We also want to relieve and manage fluid overload. So this is things like, right, doing our daily weights and I&Os, especially for right-sided heart failure patients, right? Making sure that we have fluid restrictions of like 800 to 1,500 milliliters, right? And make sure we have sodium restrictions because wherever sodium goes, water goes. So that can make that can increase more pressure on the heart. So we want to reduce sodium intake. We also want to educate the patients on how to take their medications properly and reduce any sort of anxieties. So how do we teach them about their medications? Well, if we're going to give them a diuretic, tell them, hey, take your diuretics very early in the day, not at nighttime, to prevent one, so they're not peeing in night, so they don't go to the bathroom, and they're at risk for falls, so it's better off that they have it in the daytime. Their dietary restrictions, such as low sodium diet and fluid restrictions and all of that stuff. Okay. For medications for heart failure, there's a bunch of them. So we could have digoxin, which digoxin basically increases or improves the myocardial contractility or the heart's ability to pump. So essentially, if we're giving a patient this, we want to tell them, hey, you need to make sure your heart rate is in a normal range. If it's not, they cannot take that medication, needs to hold it because digoxin can cause arrhythmias. It can cause bradycardia or other types of arrhythmias. We want to make sure that if we're administering the medication, that we need to take their apical pulse before, make sure it's normal as well. And We also want to teach the patient how to take their own pulse because when they're taking this medication at home, they need to know what to do and they need to look out for signs of toxicity, such as hypokalemia can cause digoxin toxicity. So if they're taking diuretics in conjunction with digoxin, that can be very concerning, right? So we want to watch out for their heart rates. We want to watch out for halos and nausea and vomiting and even disorientation. Those would be signs of digoxin toxicity. Diuretics, there's a bunch of different classes like loop diuretics, thiazide diuretics, aldosterone antagonists like spirulactone. But when we're talking about loop diuretics, right, such as furosemide, which we call Lasix, side effects include hypokalemia. So we have to monitor potassium levels when they're on this medication. Ototoxicity, which means they could have hearing problems, so they need to watch out for that, as well as blood pressure. They need to know how to monitor their blood pressure because they can have hypotension, and we want to tell them to change position slowly. And, right, if they're taking diuretics, right, they should be having a good amount of potassium intake as well because they could have hypokalemia. And for us to management, right, diuretics make you pee because they work in the kidneys. So we want to make sure we do INOs, daily weights. That's going to tell us if they're retaining fluid. They should not be retaining fluid. They should be peeing it out, right? That also means we should look at their urine output because we should see more urine output or an increase. We also want to watch their blood pressure and potassium levels as well as other electrolytes. ACE inhibitors, as Dr. Remy is saying, is the best drug or the drug of choice to go with for our heart failure. ACE inhibitors, though, we have to watch out for a dry, nagging cough and angioedema. So if they have a dry, nagging cough, they need to stop this and they'll be put on medications like ARBs, like losartan, or even beta blockers. But make sure we also, when they're on this medication, are watching their blood pressure as well as electrolytes because ACE inhibitors can cause hyperkalemia or high potassium levels. Metoprolol is another medication they could take, which are beta blockers. We will also want for these patients to know how to take their radial pulse and to monitor their blood pressure, right? They shouldn't be taking this medication if their heart rate's too low or their blood pressure is too low. And we should also give these medications cautiously with patients who are diabetic so that it can mask the signs and symptoms of hypoglycemia, as well as our asthmatic patients because it can cause bronchospasms. Because remember, they are also beta blockers. They block beta 2, and beta 2 has a lot to do with our sugar levels, controlling that, as well as instead of causing bronchodilation, now it blocks that and causes bronchoconstriction. There's other ones like hydralazine, ivabradine. They all basically lower blood pressure. If the heart failure is really bad, we can give inotropic agents for if the heart failure is decompensated or the body can't really do anything to increase, the perfusion to the rest of the body. So medications commonly include like dopamine, dobutamine, milrinone. And when I say inotropic, basically just means it increases the heart's contractility. And that's the purpose of them. And yeah. So the next question is to define pericardiocentesis and implement nursing interventions for a client following pericardiocentesis. So pericardiocentesis means removing fluid from the heart, or that's the fluid that surrounds the heart. So what are we looking at? Well, we want to look at vital signs, right? After the procedure, we want to look at how much fluid did we aspirate from the heart. We want to make sure we put them on a cardiac monitor and ECG because they can go into arrhythmias and things like that. We also want to make sure that we listen to the heart and lung sounds because we just removed fluid from their heart. So we want to make sure that we don't hear anything, like no muffled heart sounds. The heart now should sound clear, and that the lungs also sound clear, that no fluid accidentally leaked into the lungs and things like that. So vitals, right? Listening to heart and lung sounds, making sure you do ECGs and cardiac monitoring, as well as measuring and recording the drainage output that we got. The next question is to identify the diagnostic procedure or procedures of a client with heart failure, provide the rationale. Now, I've seen on CoursePoint a bunch of times that echocardiogram is the diagnostic test of choice. So if it was a one answer response, I would pick an echocardiogram, and that's because an echocardiogram could tell you a few different things. One, it could tell you the ejection fraction, which we already talked about why that's so important, and that it could also tell you structural abnormalities of the heart. So echocardiogram is the diagnostic test of choice. You could also do ECGs, chest X-rays, and you could do a BNP. A BNP is like a binitropeptide, something like that, and it's a diagnostic indicator of HF. If there's a high BNP level, that means they could have heart failure. So we also could look at those. Um, yeah. Just also, I wanted to mention quickly before I leave to the next question is that ejection fracture. She said 40%. If it's less than, usually, at least the textbook says it's between like 55 to 65 or 50 to 70, depending on the textbook. But just know that the lower it is, right, the more um, the heart has to struggle because it's not really able to pump properly, and that causes even more problems for the heart, right? Okay. Question 4 is to identify clinical complications of heart failure and anticipate clinical management. So she was saying that the notes that I have were that complications could include a myocardial infarction and chest pain. So if they're having chest pain, what do we do? Well, we give them nitroglycerin. If it's ordered at 4 o'clock, we give the first dose, right? At 4, wait 5 minutes, ask them how they're feeling, ask them about their pain. They're still in pain, we can give them another one at 4:05. Wait till 4:10, ask them how they're doing. If they're still in pain, right, we can give them a third because we don't give more than 3. They have to be 5 minutes apart and sublingually. But if we already are on the second one and they still need another, we want to ask the doctor if we should give another one. Also, things to consider is that with nitroglycerin, it can cause a throbbing headache, it can cause hypotension and flushing. We also want to tell the patient that tingling or a warm sensation under the tongue as they're getting the medication is normal. And we want to monitor, as a nurse, right, the blood pressure because of the hypotension. The next question is to assess and identify clinical complications of right-sided heart failure. So I already talked about right-sided, remember, it's systemic congestion. So that means we have edema, right? We have jugular vein distension. We have ascites or fluid in the abdomen. We have hepatomegaly. We have weight gain and even fatigue, right? All of those things because the blood is pooling now in the body, right? Because it can't push it towards the lungs. For nursing management, right, because we're talking about fluid buildup, we give diuretics, and we already said we need to monitor for blood pressure and electrolytes while they're on that. We also, if we give them things like ACE or beta blockers for, blood pressure, we still continue to monitor blood pressure, but if they're on ACE, right, watch out for that nagging cough. Always we got to look at lung sounds, heart sounds, because they could have fluid buildup there. Right, eventually if the fluid just gets so crazy, we want to make sure that it doesn't get to the lungs. We also want to assess heart sounds. And we also want to look at eye and nose daily weights because that's going to tell us if they're gaining more fluid, right? If they're gaining a few pounds in a day or they're not outputting as much as they're inputting, and also fluid restrictions. So we don't want to give them more fluids while they're already having problems with gaining fluid buildup. The next question is perform a physical assessment of a patient with heart failure and identify clinical signs of impending heart failure on auscultation. So something that we might hear on auscultation, right, would be an S3 gallop. If we hear that, that would be indicative that they're going into heart failure, okay? That's not normal. That's what Dr. Remy noted, so that's what I want to emphasize for that question. The next question is to conduct a nursing assessment of a client with heart failure and identify clinical abnormal findings and priority action. So, a complication of heart failure could be cardiogenic shock. And cardiogenic shock is caused when um, there's a lack of perfusion due to impaired myocardial function, um, such as through left-sided heart failure. That's one of the reasons why you have cardiogenic shock when the the left side of the heart fails, right? Blood cannot be pumped to the rest of the body. The coronary arteries aren't perfused as well. The whole body isn't perfused as well. They can go into shock. And we know with shock, we could have hypotension, tachycardia with weak pulses, oliguria from the lack of, right? Because we were talking about how the left side also, within the kidneys, how they interplay because the kidneys take 25% of like the body's blood. So they can have oliguria, which means you want to assess the BUN and creatinine levels. We want to look at the lung and heart sounds, as well as interventions. Priority interventions for cardiogenic shock usually include providing oxygen for the myocardium, because that's what it's usually lacking, as well as providing inotropic agents like dobutamine, dopamine, things like that. Okay. The next question is to conduct a physical assessment and identify expected clinical findings for a client with right-sided heart failure. We're not going to already get into that, but remember, right-sided means systemic, and you could think of those symptoms because we already spoke about them. The next question is to assess and identify clinical manifestations of a client with an acute exacerbation of heart failure. Now, I did see a course point question that said, oh, if they have sudden onset tachypnea and shortness of breath, the first thing that we want to do is elevate the head of the bed, because we always want to go to our least invasive measures first. And elevating the head of the bed, as we mentioned earlier, would facilitate breathing. Well, what would be some manifestations of an exacerbation of heart failure? Well, if they're having really bad shortness of breath, right, a labile or changing temperatures, dyspnea and peripheral edema, right, that's just getting worse. A skin assessment where the body's really cold. Heart failure patients could also go into AFib. So if we see EKGs and we see atrial fibrillation, that could be bad, and we know that they're at risk for stroke, specifically an embolytic stroke, whether it's coming from clots. So we might be giving these patients things like TPA, so streptokinase, urokinase, alteplase, and monitor for vital signs and for signs and symptoms of bleeding. Right, we want to look for the vitals, like if they're normal, but they wouldn't be if in the case, especially if they're bleeding as a result of a TPA, and looking for signs and symptoms of bleeding like hematuria or urine, blood in the urine, things like that. We can give them anticoagulants if they have AFib to prevent further clots from being made in the body. So it won't like be a clot buster like the TPAs or literally break down the clot, but these will help prevent form new clots. So we can give heparin or warfarin, and if there are signs and symptoms of bleeding with heparin, we give protamine sulfate, and if there's signs and symptoms for bleeding with warfarin, we give vitamin K. But we do tell them if they're taking warfarin to avoid green leafy vegetables like spinach. We could even give them low molecular weight heparin like Lovenox, because it's an antiplatelet, and it also helps serve as an anticoagulant. So it has, a dual purpose, which would be very good. And as we said, a risk for these patients is clotting, right? As well as is clotting, right? So they have a risk of clotting. So it's good that we can give them these type of medications to prevent complications like AFib. Or if they have AFib, we give this to prevent AFib from happening again, right? We also always want to look at lung and heart sounds as well as fluid retention, right? Like periorbital. If it's going to the face, that means it's worsening, right? Because typically heart failure patients will have, especially right-sided, will have lower peripheral edema, maybe some edema in the hands, but now it's coming to the face, which shows it's getting worse. So overall, we have to think about what shows worsening symptoms. If they have now sudden onsets of shortness of breath, dyspnea, edema, right? Cool skin, right? AFib, if the EKG shows that, maybe worsening crackles in the lungs, worsening um, or even more muffled heart sounds, right? And also, right, are they having more increased fluid retention? The next question is to identify complications of a client with heart failure and nursing management. For specifically, Dr. Marie mentions MI and AFib. So, those are some complications that you could have a heart failure. Others include pulmonary edema, right? We said pulmonary edema could be a side effect of left-sided heart failure, which causes that pink frothy sputum. We have pericardial effusion, right, where fluids building up in the heart, and that could be from, left-sided heart failure patients, right? They could become hypotensive, poor cardiac output, and cardiogenic shock, which is also due to the left side of the body, the left side of the heart failing. They can have arrhythmias, like we said, like AFib due to the myocardial conduction system not working properly, as well as thromboembolism, right, or having clots. And that could be from all the fluid buildup in the body that you see with right side affecting the venous return. So think, what are my right and left-sided symptoms for each when it comes to heart failure? And what sorts of problems can I see as a result? So pulmonary edema, pericardial effusion, right, cardiogenic shock, hypotension, arrhythmias, and thromboembolism. The next question is to indicate the most pharmacological effect for survival of a client with heart failure. She said we give ACE. ACE is our priority. If they can't get ACE, let's say they're having a nagging cough with it, we can give them ARBs and metoprolol and alternate with things like that. Okay, so chapter 26. The first question is to develop a nursing plan of care or a nursing diagnosis of a client with peripheral arterial disease. Now, I want you guys to think back of the anatomy of the vessels, such as the arteries and the veins. So, arteries, right, they're going to carry blood, oxygenated blood, to the tissues, right? So, it goes from the heart, let's just say, to your toes, right? Whereas veins take blood from the tissues and bring it to the heart. So they'll go from your feet to your heart, right? So the reason I mention it like that is understanding where the blood flows or how it flows can help you understand the symptoms and the management, right? And arterial is oxygenated blood, right? That helps keep our skin warm. That's what helps make sure that we have adequate perfusion when we're working out, right? So if you're working out or you're exercising or you're running or you're sweating, whatever, right? Your arteries are going to, or your vessels are going to dilate to send more blood, oxygenated blood to the areas that are working, right? So that your tissues don't die. And the veins' role is to bring that deoxygenated blood or the waste products back to the heart so that they can be filtered, right? So that deoxygenated blood can be filtered into oxygenated blood. So, peripheral arterial disease, going back to this question on making a nursing diagnosis, it means inadequate oxygenation in the peripheral arteries, right, or in the periphery. So a nursing diagnosis would be ineffective peripheral tissue perfusion or impaired tissue perfusion. Another nursing diagnosis could be inadequate oxygenated blood related to peripheral artery disease evidenced by intermittent claudication and diminished pulses. Now, why would we have diminished pulses? Well, the only time we get pulses is from our arteries. The veins do not contract a pulse, right? It's the arteries that have the pulse, right? We palpate our radial pulse, our carotid pulse, our brachial pulse. The arteries make pulses. So if there's a problem with the arteries or peripheral arterial disease, they could have diminished or even absent pulses. Because I already said arteries control making our skin warm, they're going to be more cool to the touch and their skin's going to be more shiny. The pain is going to be sharp pain, and that's because of the lack of perfusion. It hurts to not have the oxygenation you need for your tissues, right? It's almost like when you're in the cold, right? And if you have like your hands or your feet exposed to something really cold, it really hurts when you try to warm it back up because it's a lack of perfusion, right? They also have intermittent claudication where they have pain on walking. Why imagine, as I said, when you run, jog, jump, whatever, your arteries need to send the blood from the heart to the tissues that need it. If there's a problem with that, right, intermittent claudication, you're going to have pain when you're walking or exercising, but it's going to be relieved by rest, right? Because that means the arteries don't have to work as hard to perfuse those areas. If it gets so bad, we could have something called resting pain, which is where the arterial perfusion is so bad that it even hurts to rest because the arteries just cannot get blood anywhere. If you have loss of hair on your toes, that's indicative of an arterial problem. When the nails are thick, that's also indications of arterial. And the ulcers in if you're having an arterial ulcer is what I mean, they're gonna have regular borders and they're gonna be black and they could be or necrotic and they can have gangrene. And that's because it's a lack of perfusion and lack of oxygenation leads to necrosis or blackening, which leads to tissue death. Venous ulcers are not going to cause tissue death because they don't have oxygen in it. Okay? And remember, I said the blood goes from the heart to the feet, which means it's going downward, which means it helps to keep your feet down or in a dependent position. Whereas our veins, right, they go up. So the best way to help them, right, from the feet up to the heart. So you need to elevate the legs to help with venous return, right? They're going to have an achy, dull kind of cramping pain because it's not like an arterial pain. So you're not going to feel it as much, but it would be more like a dull, achy pain. Pulses are going to be present, right? Because remember, we said this is not, venous insufficiency has nothing to do with arterial insufficiency when it comes to pulses, but it could be difficult to palpate because of edema. That's why for both of them, you could use Dopplers, and Dopplers basically you put them on where the artery is expected so that you could hear the circulation to hear if you hear the sound. If you hear that, right, that's going to tell you, oh, you have arterial perfusion, you have pulse, you have something there. But in venous, they're going to have pulses. They just might be hard to palpate because they're so edematous. They have so much fluid buildup because of the problem with venous stasis. Now they're having literally fluid buildup because of the veins not being able to get to the heart. So that's why we'd use a Doppler. The reason you use a Doppler for arterial is to see if there even is a pulse because you can't even feel it because of the lack of arterial perfusion, right? So just different reasonings. For venous, you're going to typically see ulcerations on the dorsal or medial and lateral malleus. It's going to be really thick, large, and superficial. It's going to be red, leafy red, and like yellowish coloring. You could even have DVTs, right? But these borders are going to be more irregular, whereas arterial is regular. These are going to be irregular in venous insufficiency, right? As well as, once again, like edema. But for the nursing diagnosis, when it comes to peripheral arterial disease, will be impaired tissue perfusion, okay? So the next question is to complete a priority physical assessment of a client with PVD, define claudication, and implement nursing management for claudication, no parenteral medication in class. So intermittent claudication, as we said already, is pain when they walk, and it's relieved by rest. When we have patients who, say, oh, it hurts so much to walk, but it feels better when I sit down or I relax. So then we want to also, when we have these type of patients, to palpate their dorsalis pedis, which is the artery on top of the foot, or their posterior tibial, which is the back of the tibial, the pulse there. Like I said, you could use Dopplers to hear the pulses, as well as do an ankle brachial index. That's going to be the diagnostic test to let us know a lot about if they have peripheral artery disease. And I want to actually go into what's the numbers mean. So if you go to page 825 in the textbook, you'll see that a normal ABI is between 1 and 1.40. And for moderate to mild lack of perfusion, it's going to be 0.5. Yeah, 0.5 to 0.9. That's moderate to mild insufficiency, which you see in someone who has intermittent claudication. And if they have an ankle brachial index of less than 0.5, it's going to be found in someone who has severe ischemia, which is what we call rest pain, right? So the ankle brachial index, just for context, it compares the blood pressures in the ankle and the arm. So it's seeing how well you are adequately perfused. So us as a normal person would have a 1 to 1.4, hopefully, right? Someone who has PAD could have 0.5 to 0.9, which would be indicative, like I said, of intermittent claudication, or less than 0.50 would be ischemic and relates to resting pain, right? Because that's one of the diagnostic procedures we can do, which is also what Dr. Remy mentioned. We also remember, once again, a dependent positioning for PAD, as well as medications we can give. She mentioned Trental, and Trental decreases blood viscosity, which helps improve blood flow by decreasing the thickness of the blood. And she also mentioned Persantine, which is basically a vasodilator, so it helps open up the arteries, but it also inhibits platelet aggregation, so you don't have to worry about so much clot buildup and things like that, right? Other things that we could do is like to diagnose PAD could be a computer tomography scanning, an angiography, which uses contrast, so you want to monitor for allergies, and it could also cause a warm sensation. Um, but yeah, those are the different things that we could do when it comes to performing a physical assessment and identifying intermittent claudication. Now we know, just we already went through, right? For these type of patients, we want to increase exercise as tolerated, right? But stop activities if they have pain and put them in a lower position. Physical assessment, we want to palpate the pulses, especially peripherally, to see how that is going. And if we can't, we use a Doppler, right? We want to look at our posterior tibial or dorsalis pedis, our tibial. We want to do a skin assessment. Is it cool to touch, right? How that's going. Are they having, what's their capillary refill? Is that good? We expect it to be higher, right? Or delayed capillary refill because they have PAD. We also will use our ankle brachial index, right? We talked about medications and all that stuff. And the last thing I want to mention is on this is that we don't want to have tight clothing, because someone who has arterial insufficiency, tight clothing will cause further vasoconstriction, which means more lack of perfusion. No heating pads, because that can lead to burns and that can affect arterial perfusion, as well as we want to make sure that we tell these patients to stop smoking. And the 6 Ps of arterial perfusion include pain, pulselessness, parasynesthesia, pallor, polythermia, which is coolness, and paralysis. These are your 6 Ps of arterial insufficiency and what we look for. Okay. Now for pathophysiology of, it says define the pathophysiology of Virchow's triad. Virchow, don't know how to say it, on the development of venous thromboembolism. So venous thrombosis or venous thromboembolism, some things that we could do that Dr. Remy mentioned was we can give them heparin, right, to prevent clotting, because venous thromboembolism means a clot in the veins, right? If they have it, we want them to be on bed rest for 5 to 7 days, because we don't want the clot to dislodge and go to the lungs, which will lead to a pulmonary embolism. And they could have something called the positive Homan sign, which is basically when you take your foot and push it towards you, and it's going to cause pain in the calf. But it's not typically recommended, but it can cause redness and pain. But Virchow's triad is 3 things, right? 3 things which relates to how someone gets a venous thromboembolism. That's why we have these interventions right when they have it, so we can prevent problems. But now we need to understand how it can be caused. So that's what we do when we have it or they have it. And now we're looking at how it's caused. So Virchow's triad has 3 things. It's, or Virchow, I don't know how to say it. endothelial damage, venous stasis, and altered coagulation. So when they have endothelial damage, that could be things from like central venous catheter insertions, maybe vein damage, some problem with the pacing wires, or some sort of trauma, right? Venous stasis is when the blood flow isn't going, it's not going back to the heart somehow, right? And that could be um, because they smoke a lot, because they are at bed rest, right? Or they're obese, or they're really older in age, things like that. And altered coagulation can come from things like, as Dr. Remy said, cancer, pregnancy, oral contraceptive use, also being a smoker, right, or being a postoperative patient, things like that. So those are all the things that we want to think about, right? Is that for Cho's triad, which causes a venous thromboembolism, is endothelial damage, venous stasis, or blood flow not getting to the heart, and altered coagulation. Okay, okay, yeah, that's it. All right, I didn't miss anything. The next question is to assess and identify clinical manifestations of venous insufficiency and peripheral arterial disease and implement nursing interventions. So she just said for this, to elevate the legs to promote venous return, right? That's the whole point. We elevate the legs, as we mentioned, in someone who has peripheral venous insufficiency to promote venous return. I'm not going to go over the signs and symptoms of peripheral arterial disease versus peripheral venous disease, but just know that for peripheral venous, we want to elevate the legs, right? We could use embolic stockings or like those things that compress it, like for DVT, because it'll help promote venous return. Whereas someone who has PAD needs to have legs in a dependent position and no tighter constrictive posing, because that's going to cause vasoconstriction. Other things, it's like I said, when we're talking about PVD, we need to look at calf or groin pain for a potential DVT. We need to look at, we know that for Cho's triad, the endothelial damage, the venous stasis, altered coagulation can cause a DVT. We know that if we're going to give medication, it's going to be anticoagulants and antiplatelets, even cholesterol-lowering medications, and that's because for PAD and PVD, causes can be smoking, hyperlipidemia, or hypercholestemia, diabetics, as well as if you have hypertension. So we want to make sure we control cholesterol so they don't have any blockage and things like that, right? We know we could be looking for a positive Homan sign for especially PVI. They should be on bed rest if they have a DVT. Anticoagulants, I already said, are high risk. People include smokers, post-op, pregnant, or oral contraceptive use in cancer patients. Okay. The next question is provide nursing education of a client diagnosed with intermittent claudication and has type 1 diabetes. She said focus on foot care. Now, foot care for a diabetic is so important, right? They need to wash their feet daily, but they can't soak their feet. Okay, they need to completely dry their feet, and dry especially in between their toes, and do not put lotion in between the toes, right? They need to inspect their feet daily with a mirror so they could see if they have any cuts, blisters, or redness, because diabetics suffer from neuropathy or a problem with feeling sensation. So they could have cuts, blisters on their feet, and they don't know. We also want to make sure that if they cut their toenails, it's straight across. We don't want them to cross the legs, and we never want them to walk outside barefoot. They should always have something covering their feet. They should have shoes and socks. They should never walk around barefoot, and have comfortable shoes to walk in. Okay. The next question is to identify the pathophysiology of high-risk clients of venous thromboembolism and provide clinical manifestations and management and patient teaching. So Dr. Remy was saying, right, we know the triad, venous stasis, endothelial damage, altered coagulation. High-risk patients, we already said, would be like smokers, pregnant, um, cancer, oral contraceptive use, post-op, patients who are obese, patients who are smokers, patients who don't eat very well, not really active, right? Because venous stasis means inactivity of some, right, or being bedridden, because there's no flow of venous returns. So, things like that. And just for more context, right, a venous thromboembolism just means having either a DVT, a pulmonary embolism, or both. We know what it's caused by, the pathophysiology. Risk factors, some include being older than 65, patients undergoing surgery, we already said that, central venous catheter placement, septicemia, and even pregnancy. Those can all be risk factors for venous embolism. Okay. The next question is to prepare a plan of care for a client with hypertension and provide patient teaching on hypertension. So, right, hypertension, we're thinking about high blood pressure. Our high blood pressure patients should have a low sodium diet of no more than 2.4 to 3 grams a day. They should not smoke. They should limit their alcohol intake. Being overweight can increase your blood pressure, right? Smoking is a vasoconstrictant that affects your blood pressure. Being inactive affects your blood pressure. Um, lack of exercise, all of that, and also making sure that when they have hypertension that they need to continue on their medication regimen. If they stop taking it, right, we know they can go into um, rebound hypertension. We should also be teaching them about, hey, they should be having a DASH diet. So they should have no pickles, no canned foods, no meats or cheeses because those are really high in salt. They should be having more whole grains and increased fruits and vegetables. In order to measure their blood pressure, they should know that they should measure when they measure their blood pressure, their arms should be at the level of their heart. They shouldn't cross their feet. Their feet should be flat on the ground. They shouldn't smoke or drink alcohol 30 minutes before. And we know that in order to confirm a diagnosis of high blood pressure, we need to have two readings, not one, two. And we want to emphasize, right, lifestyle modifications and using their prescription medications, right? Such as their diuretics, right? We know what to teach them about those, right? To monitor their blood pressure, right? And we know we have to monitor their electrolytes, right? And look out for hearing problems, especially with those loop diuretics, right? But typically the diuretic of choice given for hypertension is thiazide diuretics. Then they could do, beta blockers, ACE, whatever, but thiazide diuretics are usually the choice. And we know all about our other blood pressure medications. We know that our goals is that so that the patient has knowledge of the disease management, right? So that they keep their blood pressure less than 130/80, that they have good lifestyle modifications, they have good dietary habits, right, of low sodium, and they make sure they exercise and reduce their weight. And something else that I want to mention for hypertension is that hypertension affects four major organs: your heart, your brain, your kidneys, and your eyes. So we really want to make sure that we assess their BUN and creatinine levels to assess their kidney function. They can have retinal hemorrhage, so they should have yearly eye exams. They can go into a cerebrovascular disease or have a stroke or TIA, trans ischemic attack, as a result of hypertension. And they can have things like heart failure, MIs, things like that, and left ventricular hypertrophy of the heart because of hypertension. Because remember, hypertension makes the heart work harder to pump blood to the rest of the body, and as a result, the left ventricle can hypertroph or get larger in size. Um, we also, like I said, we want them to have a good dietary regimen. They need to know to report medication side effects. Like we already talked about a bunch of different ones today, such as like with ACE, if they describe that, nag and cough, things like that. Make sure they don't use tobacco use or have excessive alcohol intake, and make sure that they have no complications, right? We want to make sure that they report no visual disturbances, right? Because we said eyes, kidneys, making sure we look at the renal functions and they should have a good urine output and no problems with BUN and creatinine, right? With the heart, they should have good pulses and rhythm, and that they don't have any signs of dizziness or headaches, because that could be signs of a stroke or speech deficits, right? Stroke could be things like a drooping face, right? Altered speech, so things like that. Um, okay. The next is provide education of a client with hypertension. Focus on the pharmacological effects of beta blockers. So beta blockers, as we said, they can cause hypotension and bradycardia. So we hold if their blood pressure is too low, let's just say it's 90 over 50 or less, and a heart rate of less than 60. We should tell our patients how to monitor their heart rate and blood pressure so they can see these things, that they cannot abruptly stop the medications as a result because they could have rebound hypertension. And we also want to tell, we need to know that if they're diabetics, then let them know, hey, these medications can mask the signs and symptoms of hypoglycemia, so you need to monitor your blood sugars very carefully. And we need to be careful with our asthmatics because it can cause bronchospasms. The next is identify the clinical complications of a client with hypertension and assess and provide clinical management and include patient teaching. So we already talked about, right, medications and things like that, like how with our diabetic and asthmatics, we probably wouldn't want to give those, but we do have to watch out for certain things, right? Um, but what are other clinical complications, right, for someone who has hypertension, right? We talked about medication issues. Well, let's just say, we're talking about an older person, we're talking about someone who's taking these medications and they're having, it can cause hypotension and it can make you feel dizzy, right? Especially when you change positions. So it'd be good for patients to use supportive devices to walk, such as canes or walkers, because of wrist fall. That's what she mentioned for this specific question. Um, Other things that I wanted to point out is, as I mentioned before, I was talking about clinical complications, so anything that has to do with the heart, the eyes, the brain, and the kidneys. So if they have absent pulses or cardiac sounds, like new sounds, they have retinal hemorrhaging or, bleeding in the eyes and uh, renal bruise and things, all not good, right? If they have any sort of complications, because remember, hypertension is usually asymptomatic. So when they start having symptoms, there's a problem. The management is not good. Something is failing here. Either they're not taking their medication regime, they're not following dietary restrictions, maybe the medications aren't working, or maybe it's just getting worse and there's something we're not catching. Because complications, as I said, think of heart, brain, kidney, eyes. So they can have left ventricular hypertrophy, myocardial infarction, heart failure. So these are our heart symptoms, right? They could have a transischemic attack or a TIA, or cerebrovascular disease, so CV, which means stroke as well. Renal insufficiency and chronic kidney disease for our renal part, and retinal hemorrhage for our eyes. The next question is to identify the most common health problems of a client diagnosis of hypertension. So, right, non-compliant. I think of this like dietary and lifestyle things. So, like, what would be common reasons? Well, if someone is overweight, they're not taking care of weight reduction, that will cause hypertension, right? If they're not eating properly, high salt diet, that will cause hypertension. If they're not being active, that will cause hypertension. If they chronically use, tobacco and smoke a lot, that will cause hypertension. If they have hyperlipidemia, that can also cause hypertension. And if they're just non-compliant. The next question is to define sustained hypertension. Now, according to the JNC7, which is one of the things, one of the organizations that Dr. Amy mentions, sustained hypertension would be a blood pressure of 140 over 90 or greater, whereas the American College would say sustained hypertension would be a blood pressure of 130 over 80 or above. If this were a singular choice question, I think I would just pick the highest blood pressure I saw at the moment. Like if it was 140 over 90, I'd pick that, or if it was 130 over 80, I'd pick that. But that's pretty much all I have for that. And she was mentioning that primary hypertension is typically not primary, sustained hypertension is usually primary hypertension, which relates to stage 1. The next question is to identify clinical complications of a client diagnosed with a hypertensive emergency, implement clinical nursing management in 24 to 48 hours, right? What are we doing? So if we see a hypertensive emergency, that means their blood pressure is 180 over 20 or greater. If we see that in a patient, we go, well, in the first hour, our goal is to reduce it by 25%, reduce that blood pressure by 25%. In 2 to 6 hours, the blood pressure should be 160 over 100. And by 24 to 48 hours after the hypertensive emergency has occurred, um, we want to have, like within that 24 to 48 hours, if we're doing all this, right, we want to have a blood pressure return to normal or less than 140 over 90. And in order to do this, we can give different medications like vasodilators, IV vasodilators, such as sodium nitroprusside, nicardipine, nitroglycerin, things like that. And because remember, we're talking about a rapidly high blood pressure, and hypertensive emergency also means that it causes manifestation. So if the question were to say, oh, I have a patient who has a blood pressure of 210 over 120, and they're having dizziness, uh-oh, that's a hypertensive emergency. Hypertensive emergency has manifestations because we said hypertension is typically asymptomatic, but in a hypertensive emergency, they have symptoms. So we need to do really good blood pressure monitoring for symptoms, and putting them on a vascular monitor, because we need to know what's going on because these patients are having manifestations. Okay. The next question is to identify a patient at risk. So something that says here is that if they have hyperlipidemia, if they're obese, non-treated hypertension, smokers. But according to the textbook, risk factors for hypertension are advanced age. If you are of African American heritage, you have chronic kidney disease, you are diabetic, you drink too much alcohol, and you have use of tobacco, your family history, if you are male, gender, obesity and overweight, if you're inactive, if you have hyperglycemia, a poor diet, a sedentary lifestyle, stress, and sleep apnea. All of these put you at risk for hypertension. And I mostly think that is okay. Any lifestyle problems, any family history, right? Because mainly hypertension, for the most part, unless it's a genetically related issue, it could be controlled, as we talked about, with weight and stress reduction and stopping excessive alcohol intake and nicotine and tobacco and all of that stuff. Um, okay. The next thing is to identify the clinical complications of hypertension and management. So we already said we're thinking about heart, kidney, brain, eyes, right? So if they have eye problems, what do we tell them? Hey, we need to make sure you go for yearly eye exams because it can cause retinal hemorrhage and visual disturbances, right? We want to watch out for stroke, right? Especially in the brain. So like dizziness, we want to tell them that signs of a stroke, like drooping face, weakness on one side of the body, right? Altered speech, things like that. They can go into an MI and have heart failure. So we want to tell them, hey, if you have chest pain that's radiating through the jaw, it's not going away with rest, go to the hospital, things like that. And yeah, she also mentioned as the last thing is that medication to keep bumetanide, which is a diuretic, a loop diuretic. So that means we monitor our blood pressure and potassium levels. Like I said, I wish I could have gotten this out sooner, but good luck studying, everyone.